I think let's proceed. I come from Brighton, United Kingdom, and on the top you see our hospital with the grand history. I don't have any financial interests. And as the chairman said, this glaucoma in keratoprosthesis is highly important because once we do with any type of kepro highly successful surgery, the glaucoma is going to be the number one killer of vision. And also for some of the reasons, the incidence of glaucoma is quite high in these cases, and there is a new onset of glaucoma with the kepro surgery, and if you already have a glaucoma, that gets worse. And most importantly, diagnosing, treating, and monitoring these glaucoma patients is very difficult. I'm going to talk about two important kepros, the Boston and then OKP. In the United States, kepro means Boston kepro, but in the rest of the world we have different kepros. And this is a quick outline of this talk. And first of all, incidence of glaucomas. The cohort of the patients we deal with in kepro surgery are very specific. If you look at the review here, 66% of these patients are prone to develop glaucoma with just ocular surface disease. And if it comes to the patients in Boston kepro, the prevalence of glaucoma is around 36 to 76% before the kepro surgery, and de novo glaucoma, which is after the implantation of the kepro, is 28%. And what about in OKP? In our Brighton series, we have this more or less a similar picture, about 40% pre-existing glaucoma, and new onset glaucoma is around 15 patients. And there's a quick snapshot of the world literature in OKP. In India, it's around 20%, and in Germany, 52%. And these are all the new onset glaucoma, so more or less they're similar. So why these patients get glaucoma? First of all, in the ocular surface disease, which is an ongoing problem in these patients despite of having a kepro. So the cause is they may be already having glaucoma because there is a predisposition with aniridia and chemical injuries where there is damage to the trabeculum. And if there is a corneal perforation happens, they develop anterior synechiae. And also the treatments which we offer, topical steroids, and especially if they have any multiple limb allografts or any conjunctival surgeries, there will be scarring, and that inhibits episcleral drainage. And with the penetrating procedures, there is always a damage to the trabecular meshwork and distortion of the angular anatomy. After the Boston kepro, apart from the above causes, the new etiology or new mechanism we induce here in glaucoma is removal of the iris and leaving the patient aphakic. That adds to the problem of glaucoma. Whereas in OKP, if you look at this picture, this is the lamina, dental-alveolar lamina, which sits on the cornea, and it compresses, or rather collapses, the trabeculum. And again, we have a thick mucous membrane here that prevents the drainage of the episcleral veins. So there is a two-way process of getting glaucoma. So in our Brighton series, we have a cohort of patients with the ongoing cicatricial disease, and also they have multiple corneal graft procedures, so there is a high risk for glaucoma. And we have done some histology of some few specimens of a few patient explanted laminas, and you can find that the trabeculum we found that trabeculum was already collapsed. It's not very clear here, it may be somewhere around. So there's a proof on microscopic level there is a damage. And how do we assess glaucoma in these patients? First of all, we all must admit that it is a very challenging area because at the moment there is no definite way of checking intraocular pressure. It's only a digital tonometry, and we all know how accurate this measure is. And in Boston kepro, tonopen can be used at the limbal area, and you're comparing with the other eye, but we're not sure how accurate it is. And interestingly, we observe that if the patients after OKP, if they complain of pain or headache, that could be a sign of raised pressure. And many of these patients get better with just oral diamox. So that's an important symptom to bear in mind. And interestingly, some patients may not have the opportunity to examine the disc. So they may already have a glaucoma before, so that may come to the surface. And field tests can be done, but bear in mind that this is a small uptick, so the fields are restricted. VP is a useful method to monitor glaucoma in some patients, and some studies have done imaging in OKPIs. And how do we treat glaucoma? We can try medical treatments, but it may be partially effective in type 1 because the cornea is replaced by the hard PMMA, which inhibits glaucoma medication penetration. There is no role of topical medication in OKP because the mucous membrane is like a carpet which inhibits penetration. But in OKP we tried oral acetazolamide. If the patient tolerates, that works very well. And some patients on oral beta blockers and also sublingual timolol. One patient had a topical treatment was effective. I don't know how he's getting. Maybe it's to some leftover pharyngeal conjunctiva. And surgical treatment for Boston Capros. And the type of surgery and the choice and the timing of the surgery in Boston Capros depends on several factors like angles, IOP, and the progression of the glaucoma and what procedure we are planning. A quick summary guide based upon published literature. Suppose you have a patient considering for Boston Capro, you may have a low-rate glaucoma or no glaucoma at the presentation, normal IOPs and open angles, and you are not planning to leave the patient aphakic. That means it may be a pseudophakic. So there is no post-op expected angle distortion. Then you can't just get it away with Capro. But if there is a moderate glaucoma and there is an angle distortion, they need glaucoma drainage device either prior to the Capro or after the Capro. If there is an advanced optic nerve damage, it may be worth controlling the glaucoma first with the tube, then going for Capro. But of course, there is a risk of inducing post-op hypotonia and more complications if you already have a tube. And what type of tube? People have used different tubes, and it basically depends on the preference. But where do you implant? It depends on the amount of scarring and the opening of the palpebral aperture. And the tubes in this Capro